name is Tiffany Stankewicz. I'm the Endometrium Product Director at iGenomics. Thank you for having me here today. Today, I've been given the opportunity to discuss endometrial receptivity and the importance of endometrial receptivity in vitro fertilization. So I'm going to go ahead and jump right into the presentation. And we're going to start with implantation in general. So live birth rates per started IVF cycle worldwide is only about 25 to 30%. Implantation is a major rate-limiting step to achieve successful pregnancy. And compared to other mammals, this process in humans is quite inefficient, where we have a high rate of embryo aneuploidy mixed with the need for endometrial receptivity guiding implantation to be taken place. As far as implantation itself, this consists of hatching of the blastocyst out of the zona pellucida, following by apposition of the trophectoderm against the endometrium, then attachment, and lastly, invasion. However, in order for implantation to take place, this intercellular interaction between the apical membranes of the endometrial epithelium and trophoblastic ectoderm must occur. At the very basic level, the major contributors to failed implantation pertain to abnormalities in either the embryo and/or the endometrium. At the very simplest level, we need a competent embryo, but we also need a competent endometrium. Now, in IVF, for many years, we focus on optimizing the embryo. And this is proof with embryo transfer day, where we've changed from early IVF doing GIFT and ZIFT to cleavage stage embryo transfer, and then lastly, blastocyst embryo transfer. We've optimized the number of embryos we transfer at a time, going from multiple embryo transfers to now elective single embryo transfer. Even the type of embryo transfer cycle has evolved, going from fresh embryo to frozen embryo transfers. And then lastly, our embryo transfer selection techniques have also improved, starting with morphology, then moving to morphokinetics, and then lastly, PGT and forms of genetics. However, these advanced techniques like PGTA does not guarantee success. In those cases, approximately 1/3 of PGTA cases end in implantation failure. We must look for another source of this failure, and that leads us to the endometrium. Looking at the endometrium in more detail, we must start with endometrial receptivity. What is this? Well, it's a complex process that permits a blastocyst to implant into the uterine lining. Endometrial receptivity itself is marked by the window of implantation. The existence of the window of implantation was first proposed in the mid-1950s. It was initially suggested that the window of implantation lasts up to approximately 10 days post-ovulation. However, in these earlier studies, they poorly defined the day of ovulation, resulting in an obvious and systematic bias in their conclusions. Later on, we redefined what was optimal versus what was possible, demonstrating that there were superior clinical rates during a 2-day window. More recently, transcriptomic assessments have demonstrated a slightly shorter window of implantation, lasting on average anywhere from 29 to 36 hours, and in some patients, less than 24 hours. In fact, we've seen patients with a marked window of implantation even less than 12 hours long. In any case, the window of implantation concludes upon the initiation of the stromal cell decidualization, which subsequently allows for the trophoblast to invade and placental formation to take place. So how is endometrial receptivity attained? Well, it's a well-orchestrated and integrated interaction of paracrine signaling, which includes factors such as hormones, growth factors, lipid mediators, transcription factors, prostaglandins, cytokines, among every other. In any case, the plasma membrane transformation must occur, leading to a change from a non-adhesive surface to an adhesive one, allowing blastocyst implantation to happen. So let's look at some of these players. Ovarian steroid hormones are the most obvious. We know that the endometrium is hormonally regulated tissue, and endometrial receptivity itself is chiefly regulated by estradiol and progesterone. The actions of these hormones are due to the presence of both progesterone receptors and estrogen receptors expressed in the epithelial and stromal compartments of the endometrium. Looking at the role of estrogen, this is the first hormone to exert its effects. This occurs in the first half of the menstrual cycle, where increasing levels of estrogen promotes endometrial cell proliferation. Then ovulation occurs and will release progesterone from the resulting corpus luteans, subsequently bringing about endometrial epithelial differentiation and maturation. By far, progesterone is the single most important hormone pertaining to receptivity and the window of implantation. Initiation of the window of implantation by progesterone has been demonstrated clinically, epidemiologically, and morphologically. Once progesterone levels reach a critical threshold, a well-timed and orderly secretory transformation can then begin. We found that even very low levels of serum progesterone, as low as 2.5 nanograms per mil, can trigger this differential expression of key genes associated with secretory transformation and ultimately the control of the window of implantation and endometrial receptivity. So let's dive a little bit deeper in how we prepare for embryo transfer in an IVF cycle. First things first, let's address endometrial abnormalities. We know that pathological modification of the uterine cavity, including things such as hyperplasia, submucosal myomas, endometrial polyps, endometritis, among others, accounts for about 18 to 20% of repeated implantation cases. These pathological uterine anomalies should be addressed prior to an embryo transfer. So for example, in the case of endometrial polyps, surgical interventions can take place. And in the case of something such as endometritis, personalized antimicrobial therapy can be administered, clearing the patient's endometrial cavity of any bacterial pathogens. Nevertheless, patients can still endure implantation failure without ever identifying an obvious cause or having such endometrial anomalies present. So how do we prepare the endometrium for preparation for embryo transfer? So traditionally, embryo development was the guiding factor for transfer timing in an IVF cycle. And this was based on the assumption that the window of implantation is constant in all women, initiating around cycle day 19 to 20 and remaining open to 4 to 5 days. However, we now know that this is not true. In any case, though, when an embryo reached, say, the cleavage stage on day 3, we would transfer day 3 of uterine prep, day 5, et cetera, pretty much at the same time. So again, day 3 embryo, about 3 days of progesterone exposure, and a day 5 or even sometimes a day 6 embryo on about 5 days of progesterone exposure. When preparing the endometrium for embryo transfer, synchronization is key. And the synchronization I'm referring to is between the implanting blastocyst and a receptive endometrium. For example, in natural conception, embryonic development and the window of implantation are controlled by the follicle, where following ovulation, progesterone begins to rise, and if both the resulting embryo and endometrium develop normally, and they are synchronous, we can expect implantation to occur. However, in IVF cycles, this natural coordination may be lost, and even when we control for a proper embryo development on day of transfer. So for instance, if we were planning a day 3 transfer, we want to see an embryo about 6 to 8 cells, and on a day 5 transfer, we want to see an expanded blastocyst with a clear inner cell mass and trophectoderm. However, in these IVF cycles, supraphysiological levels of steroid hormones during controlled ovarian stimulation can deteriorate uterine receptivity. We see in these cycles that progesterone rises prematurely at a much faster and more vigorous rate following ovulation trigger versus LH surge in a natural cycle. This itself can lead to early secretory transformation. In essence, we could be shifting the window of implantation by 16 to 24 hours, leading to a dysynchrony between the implanting embryo and the receptive endometrium. We know that delayed blast dilation, especially in older patients and low responders, may be another source of dysynchrony. However, when we account for this in frozen embryo transfer cycles, we see improved clinical rates are observed. This further highlights the need for proper synchronization between these two players. So what is the standard assessment of endometrial receptivity in IVF? Well, the most obvious is monitoring of hormone levels. We know that estrogen and progesterone is imperative for endometrial proliferation and receptivity. So these are our classic parameters in order to monitor the window of implantation. As I mentioned, estradiol and progesterone concentrations are the primary hormonal determinants for transfer timing. And we know that specific serum thresholds have been correlated with IVF success. Additionally, exogenous estrogen and progesterone are often administered in hormone replacement therapy cycles to further control the treatment. However, optimal administration types, dosage, and durations have not yet been established. The other standard parameter for assessing ART cycles to indicate when the endometrium is adequate for embryo transfer is measuring of endometrial thickness. This is often measured by transvaginal ultrasound. And we've seen reports of atrophic endometrium, that's very thin linings, less than 6 millimeters, and hypertrophic endometrium, so those endometriums 14 millimeters and above, have been associated with lower clinical rates. However, the reproducibility of these studies are lacking in that others have found that neither an atrophic or hypertrophic lining is associated with decreased ART success. In essence, endometrial thickness is not a reliable diagnostic tool for endometrial receptivity. Due to the limited capacity to identify patients with a decreased probability of conceiving following an embryo transfer, the utility of using endometrial thickness to guide the fate of an IVF cycle should be reassessed. Now, this leads me to a bit of a controversial topic, which is endometrial scratching. This is a deliberate injury made to the endometrial lining. This can be from manipulation during a hysteroscopy, an endometrial biopsy, or curettage. The methods for improved implantation, the proposed methods, I should say, include stromal cell deciddualization, inflammatory response, and delayed endometrial maturation and controlled ovarian hyperstimulation cycles to encourage proper embryo and endometrial synchrony. However, as I mentioned, endometrial scratching is still controversial at best, as there's no clear consensus on when within the cycle to perform the scratch. Do we perform in the secretory phase? Do we perform just prior to ovulation? And then how long before the embryo transfer do we perform the scratch? Do we do it in the cycle before, the cycle of, 3 months before? Additionally, we don't have the best method for performing the scratch. Is it indeed manipulation during the hysteroscopy or an endometrial biopsy? In any case, clinical results show no clinical value, and this translates to endometrial scratching, again, being quite a controversial topic. We also must consider the cost to the patient, which includes pain, monetary costs, and the potential for damage following the procedure. In any case, endometrial scratching is empirical, unproven, and possibly harmful, hence is not part of the standard ART practice. So let's go a little bit further when assessing endometrial receptivity. Which is really the best time for transfer? We discussed before monitoring hormone levels is the key, but does this truly tell us when the embryo should be transferred? The most important question here is not if an endometrium can be receptive or not, but when is it going to be receptive? Histology was introduced in the 1950s, and this was a way in order to date the endometrium. Until recently, histology was considered the gold standard for endometrial dating. This particular technique was developed according to the criteria established from laboratory observations of approximately 8,000 endometrial biopsy samples. The criteria itself are based upon variations that occur throughout the endometrial phases. The clinical utility and accuracy of this method, though, has been vehemently questioned. There's a number of RCTs and prospective studies showing extensive intersubject, and interobserver variability. Additionally, innate biases to the protocol itself, such as tissue fixation artifacts, translates to histology lacking reliability and to adequately evaluate the luteal phase and subsequently guide the treatment for women undergoing ART. Now, in the 1990s and early 2000s, biochemical markers came to a prominent place within our market. These proposed informative markers include integrins, Mus1, calcitonin, and leukemia inhibiting factor. However, none of these biochemical markers have been successfully translated into clinical practice, as we lack a clear understanding about their interactions in endometrial receptivity, and they also lack a clear clinical directive. So, for example, if we do see levels of one of these markers that may not coincide with what endometrial receptivity should be, how do we account for this in our patient treatment cycles? We must also remember that receptivity itself is a very complex and multifactorial process in which it's impossible to summarize with the analysis of just one or even a few of these molecules. Furthermore, using single biochemical markers to draw associations with recurrent pregnancy loss, implantation, or even unexplained infertility is not practical due to the multifactorial origins of these infertility factors. More recently, transcriptomics have come to attention. This is the study of mRNA molecules expressed in the genes of an organism. Gene expression patterns in general, specifically in tissues, allows us to diagnose pathological conditions such as cancers, and also to understand physiological processes better, which we see here, an example of the transcriptomic profile of the endometrium, in which we refer to the window of implantation or receptive endometrium as a transcriptional awakening. You can see here in the receptive phase, we have many genes turned on, whereas in previous phases of the endometrium, such as the pre-receptive or post-receptive genes profiles, we see genes more so turned off. So what about endometrial transcriptomics further? The study of endometrial transcriptomics has led to improved understanding and assessment of pathologies relating to endometrial cancer, endometriosis, and recurrent implantation failure. Transcriptomic profiling of the endometrium throughout the various stages has provided further insight to the general physiology of this tissue, and also the opportunity to innovate new clinical tools that leverage this science. One of the most advantageous uses of endometrial transcriptomics has been the utilization of studying endometrial receptivity in order to increase the probability of implantation following ART. Transcriptomics in general allows for greater objectivity and a more reliable diagnosis. Now, this brings me to the endometrial receptivity analysis, or ERA test. The ERA is the first transcriptomic test for endometrial receptivity. Here, we introduce the concept of a personalized window of implantation. As I mentioned before, the dogmatic view of that every woman had a consistent window of implantation occurring at the same time, in which the window opened for 4 to 5 days, has obviously been challenged, and we know that it's not true. We now know that each woman has her own personalized window of implantation where receptivity may not occur at the expected time, i.e., about 5 days of progesterone exposure. In any case, the ERA test applies next-generation sequencing to an endometrial biopsy sample to examine the gene expression of 248 genes associated with human receptivity. There's been established differences in the transcriptomic profiles between receptive and non-receptive endometrium. If you recall, several slides back, I mentioned that in the receptive phase, we see a transcriptomic awakening where many genes are turned on. Then a bioinformatic predictor was applied that accurately diagnoses the phase of receptivity and also provides a recommendation for a personalized embryo transfer based upon a patient's own personalized window of implantation. In any case, this provides an actionable directive for a more individualized approach to embryo transfer, and hence enhancing synchrony between the implanting blastocyst and a receptive endometrium. Here again, we show the gene profiles associated with a proliferative endometrium, so one that has not yet been exposed to progesterone, a pre-receptive endometrium, one in which the window of implantation has yet to open, a receptive endometrium, in which is the ideal time for blastocyst transfer and implantation, and the post-receptive endometrium, one in which the window of implantation has already passed and is now closed. So how does ERA stack against the previous gold standard for endometrial dating, i.e. histology? So the ERA test was validated against histology. Now, in this particular study, endometrial biopsy samples were taken and split into three. Two of the samples were individually diagnosed by pathologists for histology and one by the ERA test. And what was found was that there was poor inter-observer variability and with the histology test. So for example, with pathologist number 1 might call pre-receptive, pathologist number 2 may call post-receptive, albeit it was the same endometrial biopsy sample. In the end, ERA was found to be superior to traditional histology in detecting the receptive, pre-receptive, and post-receptive endometrial phases, concluding that the molecular platform offers more objective results with greater precision. As far as reproducibility of endometrial transcriptomics from month to month, it has been tested specifically with the ERA that the results are reproducible up to 40 months. It may be greater than this when replicating cycle conditions. Although we notice some gene-to-gene differences, the transcriptomic profiles overall remain consistent even after 3 years. What was very interesting that we saw was that transcriptomic profiles within the same woman, even taken 29 to 40 months apart, were found to be much closer compared to the profiles of the control samples within the same menstrual phase. So for example, if we had several patients that tested pre-receptive, the patient's own samples, even up to 3 years apart, their genomic profiles were found to be much closer than the other patients within that same endometrial phase. Unlike histology, in which variations up to 60% have been observed in secretory features between cycles, transcriptomic variation from cycle to cycle is relatively uncommon, allowing for the test to be applied month after month. Now, I do want to share some global data regarding receptivity rates. So this is specific to the ERA test, which the main or the major indication is patients with recurrent implantation failure. So again, this data is based upon that. We see that approximately 61% of patients are going to be receptive at the expected time of transfer. Hence, they are not going to have a displaced window of implantation. However, about 32% of patients are going to be non-receptive. And these are the patients that can benefit from adjusting their window of implantation based upon their personal results. So in these cases, they may need 24 hours more progesterone exposure prior to transfer in order to properly synchronize the implanting blastocyst with a receptive endometrium, or they may need less progesterone exposure, even down to 12 hours, as in the case of a late receptive result, which, interestingly enough, we have previously associated with a risk for biochemical pregnancy. Now, I'm going to wrap up this presentation. However, I wanted to emphasize some conclusions. One, the endometrial factor plays a key role during the implantation process. I hope that this is clear because, as I was saying, for many years, we focus on optimizing the embryo and not giving much attention to the endometrium. Secondly, although most women are receptive at the standard window of implantation, i.e. progesterone day 5 in an HRT cycle, or LH+7 or HCG in a natural cycle, some of them reach receptive phenotype earlier or later, indicating a displaced window of implantation. And then lastly, to increase the probabilities of getting pregnant, it is important to synchronize the viable blastocyst with the receptive endometrium through the personalization of the embryo transfer. So I would like to thank you for everyone's time and for listening to my presentation. I look forward to hopefully answering any questions that may have come up. Thank you.